Welcome to the 2021 World Health Organization Classification of Brain Tumors. This comprehensive review covers the molecular diagnostics and clinical integration of brain tumor classification systems. Learning objectives. By the end of this presentation, you will understand the evolution from morphological to molecular diagnostic criteria, learn the major changes in the 2021 WHO classification system, explore diagnostic molecular assays and their applications, master the classification of adult-type diffuse gliomas, understand pediatric-type glioma classifications, and integrate molecular findings with clinical practice. Evolution of brain tumor classification. The diagnostic framework for brain tumors is continuously evolving and iterative. There has been a fundamental shift from standard morphological features interpreted under the light microscope to molecular diagnostic criteria defined at the level of nucleic acids and proteins. This shift has been driven by next-generation sequencing technologies that have revealed recurrent alterations in tumors with shared morphological, anatomical, and demographic features. Incorporating these data into clinical practice is enabled by increasing access to lower-cost next-generation sequencing assays at academic centers and through commercial laboratories. Moreover, in the last 5 years, newer molecular modalities that test for the presence or absence of epigenetic biomarkers have initiated a revolution in neuropathology and are likely to become pervasive in pan-cancer oncologic practice. Major changes in 2021 WHO classification. Several major changes in practice were introduced with the 5th edition of the WHO Classification of Central Nervous System Tumors. First, molecular grading of adult diffuse gliomas has been introduced. Second, many new entities within the spectrum of pediatric gliomas and glioneuronal tumors have been introduced. Third, there has been widespread adoption of methylation classes as useful or even necessary diagnostic criteria. Additionally, several revisions to nomenclature have been introduced for simplicity and to disambiguate from other tumor types. The nomenclature has changed from Roman numerals I through IV to Arabic numerals 1 through 4. Terms such as anaplastic that were used in many ways as a redundant marker of tumor grade have been dropped in most instances. Diagnostic molecular assays. As increasingly detailed molecular profiling is necessary not only for the precise classification of central nervous system tumors, but also for trial enrollment and targeted therapy planning, a wide variety of molecular assays have been developed and adopted in both academic and commercial settings to serve these needs. Below is a brief discussion of the capabilities and best uses of several of the most widely used tools. Immunohistochemistry, rapid assessment. The development of variation-specific antibodies has permitted rapid and accurate assessment of many tumors characterized by diagnostically or therapeutically relevant gene variation events. Notable examples include IDH-132H, H3K27M, and BRAF5-600E. The advantages of immunohistochemistry include rapid turnaround time, usually less than 24 hours, ubiquitous technology, and low cost, approximately $40 per stain. However, diagnostic immunohistochemistry is only available for a relatively limited number of tumors, and many stains are difficult to perform or interpret consistently. Fluorescence in situ hybridization of FISH. Similar to immunohistochemistry, FISH has been employed for many decades and may be utilized in select instances where highly specific gene rearrangements or copy number changes are diagnostic. For example, FISH has long been the gold standard test for 1p and 19q codeletion assessment. Break-apart probes are highly effective at demonstrating gene fusions or rearrangements and can be used to confirm the presence of such an event suggested by microarray or sequencing analysis. The cost of FISH analysis can be as low as $100 per sample, and turnaround times vary from 1 to 7 days depending on source material and technique. Given that most probes range from 150 kilobases to 500 kilobases in length, precise determination of fusion partner or amplicon size is generally not possible without using multiple probes. Polymerase chain reaction (PCR). Polymerase chain reaction assays are another set of single gene tests that in general provide rapid turnaround times and highly sensitive screening. These tests, using either droplet digital or reverse transcriptase methods, focus on a small region of a gene that contains specific gene variation hotspots, such as codons 132 and 172. In IDH1 and IDH2, respectively, these tests may often be performed in combination with or in place of more comprehensive assays when tissue is limited or results for a particular variation, for example, BRAF, VIV600E, are needed for rapid treatment planning. The cost for such tests is generally less than $200 per sample. Chromosomal microarray analysis. Chromosomal microarray is a dedicated high-resolution genome-wide copy number assay. Many institutions offer single nucleotide polymorphism array testing for both neoplastic and constitutional genomic testing, which carries the additional advantage of ploidy and copy-neutral loss of heterozygosity assessment. Given the prevalence of diagnostic and prognostic copy number changes in gliomas such as +7, -10, CDKN2A deletion, 1p and 19q codeletion, and C19MC amplification, chromosomal microarray testing has particular value for central nervous system tumors. Although chromosomal microarray cannot detect balanced translocations, the majority of relevant fusion events in brain tumors result from focal intrachromosomal duplications or deletions, producing the characteristic KIAA 1549 BRAF fusion in pilocytic astrocytomas. Next-generation sequencing, NGS. A wide variety of next-generation sequencing platforms have been developed in both commercial and academic settings, ranging from small panels to whole genome coverage. Many institutions have adopted medium-sized custom panels covering 150 to 500 genes of interest, often with additional intronic regions where hotspot breakpoints occur in common fusion events. These tests are also capable of detecting amplification and deletion events, and larger panels may offer comparable copy number detection as microarrays. While most next-generation sequencing platforms are DNA-based, additional dedicated RNA platforms are available using either amplicon or hybrid capture methods to detect a wider variety of targeted fusion events. These assays generate large amounts of data that require extensive processing and bioinformatic analysis. As a result, testing costs up to several $1,000s and takes several weeks to generate results. Methylation array profiling. In 2018, a seminal article showed that array-based DNA tumor methylation profiling combined with machine learning techniques can robustly characterize and classify a diverse set of central nervous system tumors. Moreover, methylation profiling over many cases followed by unsupervised clustering has played a key role in fine-tuning the taxonomical hierarchy of central nervous system tumors. The effect may be one of lumping or splitting. A salient example of the lumping phenomenon is the creation of a new diagnosis, embryonal tumor with multilayered rosettes, which encompasses three entities previously considered to be distinct based on histologic patterns. On the other hand, clinically relevant subcategories of historically solitary entities have emerged, exemplified by the evolution of well-defined medulloblastoma subtypes. Adult-type diffuse gliomas. The discovery of recurrent variations involving isocitrate dehydrogenase encoded by IDH1 and more rarely IDH2 in diffuse gliomas has transformed our understanding of tumors that historically comprised diffuse astrocytomas, including glioblastomas, oligodendrogliomas, and oligoastrocytomas. While the initial discovery of IDH gene variations in gliomas was made in a subset of glioblastomas, it was immediately apparent that those glioblastomas with IDH variations were quite different from their IDH-wildtype counterparts. They tended to occur in younger adults and arose from lower-grade tumors that had presented years earlier. This led to the discovery that a high percentage of tumors that had been diagnosed as lower-grade diffuse astrocytomas and oligodendrogliomas harbored IDH variations. Combined with the discovery that 1p and 19q chromosomal deletions were characteristic of tumors with oligodendroglioma morphology, the stage was set to define three major classes of adult-type diffuse gliomas. Adult-type diffuse gliomas grading. The three main categories of adult-type diffuse gliomas are astrocytoma, IDH-mutant, oligodendroglioma, IDH-mutant, and 1p19q codeleted, and glioblastoma, IDH-wildtype. Each category is further graded based on World Health Organization Central Nervous System tumor grade. Astrocytoma IDH-mutant is graded 2, 3, or 4 based on the presence of mitosis, microvascular proliferation, and necrosis. Oligodendroglioma IDH-mutant and 1p19q codeleted is graded 2 or 3. Glioblastoma IDH-wildtype is always grade 4. Astrocytoma IDH-mutant, a diffuse glioma with an IDH gene variation and that lacks 1p and 19q codeletion, is now the gold standard diagnostic definition of this tumor. In about 90% of cases, the IDH variation can be detected quickly with immunohistochemical staining for IDH1R132H, the peptide product of the most commonly encountered missense variation in the gene. However, in approximately 10 to 15% of cases, the variation is only detected clinically by sequencing the IDH1 and IDH2 genes, which may reveal R132C, GS or L substitutions, and rarely IDH2R172KM or W variations. With a diagnosis of astrocytoma IDH-mutant assured, the pathologist is still tasked with designating a central nervous system WHO grade. While historically grade assignment was purely a histologic endeavor, times have changed. Just as molecular findings may dictate the tumor class itself, they may also dictate tumor grade within a class. Oligodendroglioma, IDH-mutant and 1p/19q codeleted, uniform infiltrating cells with round, regular nuclei and perinuclear halos accompanied by delicate branching vasculature and calcifications. The prototypical oligodendroglioma morphological features, sufficient for a diagnosis of oligodendroglioma in years past, are now superseded by the detection of IDH variation and 1p and 19q codeletion. The co-occurrence of these alterations is now both mandatory and definitional of oligodendrogliomas, irrespective of cellular morphology. While many centers still assess 1p and 19q copy number via fluorescence in situ hybridization, this methodology typically assesses only a small region of each chromosomal arm via a single probe on each arm. Very focal deletions may lead to false positive results relative to the biologically relevant alteration that requires whole arm loss of 1p and 19q resulting from an unbalanced translocation involving the opposite arms. Thus, the use of additional methods to interrogate each chromosomal arm more broadly may be necessary when FISH results do not align with other information relevant to the case. Glioblastoma IDH-wildtype. Glioblastomas remain the most malignant form of primary gliomas recognized in adults with a median survival time of 1 year in the absence of adjuvant therapy. Such therapy typically includes the alkylating agent temozolomide and radiation therapy, the standard STRUP protocol against which newer clinical trials are compared. Current definitional criteria of glioblastomas comprise a combination of histologic and molecular features with the prerequisite that the tumor is a diffuse astrocytic glioma lacking IDH variation and that pediatric-type diffuse gliomas have been excluded. To meet criteria for a glioblastoma, the tumor must harbor at least one of the following: microvascular proliferation, necrosis, TERT promoter variation, EGFR amplification, or the combined presence of chromosome 7 gain and chromosome 10 loss. Case 1. Glioblastoma diagnosis. This case illustrates a 71-year-old woman with a history of multiply recurrent ovarian carcinoma who presented with 2 weeks of feeling occasionally lightheaded. She was found unresponsive at home after a severe episode of lightheadedness, and subsequent MRI showed an expansile T2-weighted hyperintense, non-contrast enhancing lesion within the right mesial temporal lobe. A biopsy demonstrated mildly hypercellular brain tissue suspicious for a glioma. Given the non-diagnostic histology, the material was submitted for targeted panel sequencing, which showed polysomy for chromosome 7, monosomy of chromosome 10, and a truncating variation in PT10. No variations in IDH1 or IDH2 or TERT promoter were identified. Based on these findings, the decision was made to treat it as a glioblastoma. A completion resection was performed 5 weeks after the initial biopsy, and the histology at this time showed classic histology of a glioblastoma with densely cellular tumor and microvascular proliferation. MGMT testing showed an absence of promoter methylation, and despite standard treatment with temozolomide and radiation, the patient died of the disease 17 months later. Pediatric type diffuse high-grade gliomas. Gliomas arising in the pediatric population are characterized by unique molecular alterations that distinguish them from adult high-grade gliomas. The 2021 WHO Central Nervous System Tumor Classification has thus introduced the explicit terms adult type and pediatric type gliomas to refer to these tumor classes, while allowing for the possibility that an adult type glioma may occasionally present in a child and vice versa. In addition to outlining the many changes in the 2021 WHO Central Nervous System Tumor Classification System, this article summarizes the molecular diagnostic tools now required to characterize many of these tumors. Diffuse midline glioma H3K27 altered. In 2012, two groups concurrently reported that H3F3A, the gene encoding the histone protein H3.3, is recurrently altered in high-grade gliomas arising in children. Interestingly, the same gene may harbor variants at two different codons in a way that is predictive of the anatomical location of the tumor, with recurrent K27 alterations seen in midline gliomas and codon G34 variations seen in cerebral hemispheric gliomas. For clarity, it should be noted that the current molecular nomenclature denotes the affected codons as K28 and G35, which become the 27th and 34th residues within the protein product only after the initial methionine is cleaved post-translationally. Diffuse midline gliomas with H3K27 alterations are characterized by widespread loss of the epigenetically important trimethylation mark at lysine residue K27 of H3 histone proteins, H3K27Me3, even in proteins derived from wild-type alleles of H3 genes within the same tumor cells. Loss of H3K27 Me3 can be demonstrated simply and cost-effectively by immunohistochemistry and is essential for the diagnosis of diffuse midline glioma H3K27 altered. Diffuse hemispheric glioma H3G34 mutant. The same gene most commonly implicated in H3K27 altered tumors, H3F3A, also harbors variants at a different site, G34 or G35 if including the initial methionine residue that is cleaved during translation, in tumors arising in teenagers and young adults and within the cerebral hemispheres, in contrast to midline locations. Most tumors additionally show both TP53 and ATRX variation. Note that, as with K27 altered midline gliomas, even in the absence of histologic features historically regarded as high grade, such as microvascular proliferation and necrosis, a central nervous system WHO grade of 4 still applies as long as the requisite histone variation is demonstrated. Outcomes are poor with a typical survival time of 1.5 to 2 years. Infant-type hemispheric glioma. These recently described and rare tumors arise almost exclusively within the first year of life as large hemispheric masses that may involve the overlying leptomeninges. They are driven by fusion proteins involving one of several receptor tyrosine kinases, including those encoded by NTRK1, NTRK2, NTRK3, ROS1, ALK, or MET. Their histology may resemble that seen in classic glioblastomas. In addition to the identification of the relevant fusion driver, methylation array profiling may also be used to make this diagnosis. Pediatric type diffuse low-grade gliomas. Pediatric type low-grade diffuse gliomas are molecularly distinct from their adult type counterparts and do not exhibit IDH variations by definition, although, as mentioned, on occasion adult type IDH-mutated tumors may arise in younger patients. Instead, many pediatric low-grade gliomas are driven by oncogenic fusion events. These include fusions involving the MYB and MIBL1 genes, which when detected are incorporated in the diagnostic name, for example, diffuse astrocytoma, MYB altered. These tumors frequently present in the temporal lobe of patients with epilepsy. In some cases, there is an angiocentric arrangement of tumor cells, and when this is particularly prominent, often in cases with the MYB-QCOI fusion, the tumor may be designated as an angiocentric glioma, a tumor with a methylation profile that overlaps with other MYB-altered tumors. Key molecular markers in brain tumors. IDH1R132H demonstrates a triple variant immunohistochemical pattern that is highly specific for IDH-mutant astrocytomas. TP53 is an indicator of poor prognosis in IDH-mutant astrocytomas. ATRX loss is highly predictive of a truncating ATRX variation. TERT promoter variations characterize oligodendrogliomas and glioblastomas. EGFR amplification is a marker of glioblastoma. CDKN2, a deletion, is a harbinger of poor outcomes. Integrating molecular findings with histology. Molecular findings may dictate the tumor class itself. Molecular alterations may also dictate tumor grade within a class. The detection of homozygous deletion of the CDKN2A locus, located on the short arm of chromosome 9 and encoding the well-described tumor suppressors P16, INK4A, and P14ARF, is sufficient for a designation of central nervous system WHO grade 4 in this class. In fact, deletion of this locus as a harbinger of poor outcomes is somewhat of a recurring theme in central nervous system tumors, as we shall see in subsequent sections. Even in the absence of CDKN loss, however, a grade of 4 is assigned in the presence of microvascular proliferation, necrosis, or both. Keen observers will note that in the past, such neoplasms would have been called glioblastoma IDH-mutant. The new standard is that these neoplasms are termed astrocytoma, IDH-mutant, central nervous system, WHO grade 4, and the term glioblastoma is reserved for adult-type IDH-wildtype tumors. Recommended testing strategies. Comprehensive profiling of central nervous system tumors via chromosomal microarray or next-generation sequencing panels is frequently needed to resolve more complex differential considerations and to classify tumors with variable genetic profiles. Methylation profiling of central nervous system tumors has grown highly valuable for the creation of machine learning-based classifiers, and some tumor types cannot be accurately classified without obtaining a methylation profile. Adult diffuse gliomas are largely classified on the basis of IDH and 1p19q codeletion status. Oligodendrogliomas are recommended for whole-arm 1p and 19q testing via fluorescence in situ hybridization, whole-arm microarray, or next-generation sequencing. Clinical implications and future directions. The classification of brain tumors continues to grow in complexity alongside our improved understanding of their nuanced molecular underpinnings. Molecular diagnostics are essential for accurate classification. Prognosis varies significantly by molecular subtype. Treatment planning is increasingly guided by molecular findings. Emerging targeted therapies are based on specific alterations. Continued refinement of classification will occur as data accumulates. Integration of histology and molecular features remains essential for optimal patient care. Key takeaways. The 2021 WHO classification represents a paradigm shift to molecular diagnostics. Multiple assay platforms are available for different diagnostic contexts. Adult-type gliomas are classified by IDH and 1p19q status. Pediatric-type gliomas are driven by histone and fusion alterations. Molecular findings increasingly dictate diagnosis and prognosis. Integration of molecular and histologic data is essential for optimal patient care.